Hello everyone. This is Shailesh Hadgaonkar from Pune, and first I would like to wish all of you a healthy and happy new year. This is the ASSI initiative of Journal Club, and a great activity started by the team ASSI. I would like to thank Dr. H.S. Chabra sir, Dr. Ajoy Shetty, Dr. Gautam Zaveri, and all the team for giving us this opportunity to discuss and speak about research papers that influenced my practice. And recently, we started doing OAM navigation in last year, and that is where we have realized that it was actually a game changer, or it has changed our practice quite significantly. I would like to talk about where it began 17, 18 years back when I joined Dr. Bojraj, initially as a clinical associate, then as a fellow, and subsequently as an associate with the team. And this is where we started getting great learning from the stalwarts in spine surgery, my senior colleagues and friends, where we begin our practice. Today, when we see such patient who comes to the clinic, then we realize 9-year-old boy comes with lower limb weakness, significant deformity, and you see that the parents are expecting a lot from you, and it's difficult for sometimes for us to give the best what we can, and we realize, why me, why so late, can I deny this operation? It's just starting of a weakness in the lower limbs. What or should I refer this patient? What actually should I do? And we have done these surgeries in the past, and we have our own share of experiences. And it is something which is a very, very complex, rigid spinal deformity, kyphoscoliosis, and we all have seen this kind of images, and at times it becomes difficult when we are doing it with free hand. And these are what Dr. Raj Shekharan has described in his classification, type 3C. This is type 3C, or maybe next one to type 3C. That's what I would say. This is a lambda deformity, kind of anaconda spine with very, very severe kyphus, acute angular, and at times we realize we need some help, and it can be nothing better but OAM and navigation. We all have seen our mentors and seniors who have sailed through the era of 70s and 80s and 90s, where they started their practice. They used to do spine surgery with x-rays and myelograms, and it must be very challenging when you see these kind of images. And spine is evolving from those days, and in the 21st century, we have quite significant advancement in terms of minimal access surgery, the PET scan, the advanced MRIs and techniques. Therefore, the spine surgery is becoming better and safer for the patient anyway. This is the famous book by Atul Gawande. We all know Atul Gawande is one of the most celebrated surgeon in the US, and this is the international bestseller named Complications. What it mentions is 97% of the time, if you come to a hospital, everything goes well, but 3% of the time we have major complication. And this is a surgeon's notes on an imperfect science, and I think this is a must read book for all of us. And we always try to do our best to give the possibly good answer to the family in complex scenarios. And this is where we have issues. We always know spine people are really scared in India, and they always feel a lot of things. They talk about various stories and how these things will change in future. What changed our practice in recent time is the navigation and the superadded OAM. We were seeing this in various conferences in last 5-6 years, and we were getting to know about the advances, but we were a little skeptical how really it will help, and whether it is going to be a big change in our practice. And we went through some important papers in this related to navigation and OARM in spine surgery. As we all know, all these things are evolving. Every year we are seeing some big new changes, and all these are going towards mainly the safety and efficacy, accuracy about the procedures. Demanding situations like pedicle screw in cervical spine, cervical deformity, rigid kyphoscoliosis, revision spines, spinal tumor surgeries, congenital issues. All these things can be there in everyone's practice, but if we realize we really need help, and nowadays with advanced gadgets we are definitely getting like 3D and bone models, we are getting a lot of idea about dealing with these situations. And definitely I can say that this robotic and OARM navigation surgeries coming in all the fields, and spine surgery is no different. And this is where some important papers I would like to discuss. And this is one of the prospective studies published in 2015 by Shin et al., which studies between the fluoroscopic guided and navigation coupled with OARM guided pedicle screw placement in thoracic and thoracolumbar spine. And this is a Korean paper, one of the early paper in Journal of Spine Disorder and Techniques, where they have studied around 138 patients with fluoro-guided screws and 124 patients with OARM-guided navigated screws. What was the outcome? They found 87% of accuracy in the CARM group and 91% accuracy in OARM group. This was the initial paper, and it showed that the mean time required for screw placement was 3.7 minutes versus 4.3 minutes in OARM in their study. When we realized in the discussion, something which was very important, which came out, and it was Silberman et al. Reported 99% of accurate placement in OARM navigated group in his study, whereas the CARM guided group showed about 94% of accuracy in pedicle screw placement and breach of cortices, which is around some amount of difference between the CARM and OARM. We are always, we have done freehand technique with CARM guided for many years, and we always feel we are doing the exact placement, but sometimes when we analyze, there are small amount of errors which happen, and that is with every one of us. The conclusion was accuracy of OARM was better, and it was the more accurate and safer in OARM guided group. And this is just a basic
the OARM surgical 3D imaging system allows neurosurgeons and orthopedic spine surgeons to view highly detailed real-time images of the spine during surgery. The 3D images are displayed on a large monitor, allowing the surgeon to see exactly where to place surgical instruments and implants while carefully maneuvering around spinal nerves and nearby organs.
I just wanted this video because there are a lot of things which are happening. We feel that it's a very bulky machine, but it is very easily maneuverable machine. One person can take this machine in and out of the theater. And nowadays, the amount of radiation is significantly less. I will be talking about that also in the other papers, but it is 13 seconds are required for the screening by the CARM, and it is integrated with the still station. It is a navigation which gives us all the additional information for screw placement. These are the situations where I felt it's changing our practice, and mainly the revision spine, twice or thrice operated, spinal deformity, severe complex deformities, spinal tumors also, a cervical pedicle screw in selective situations, and minimal invasive spine surgery, where we have our experience, and I'll be sharing that as well. This is one of the observational study and one of the important original article published in Eurospine by Tazik et al. And they're talking about The navigation for minimally invasive spine surgery in thoracic and thoracolumbar fixation, implications for radiation exposure, operative time, and accuracy of pedicle screw placement. This is a very, very important paper for all of us, and we just thought of understanding it better, where they have done a retrospective study of 152 patients, where it was not similar, because 96% of the 96 patients were with 2D fluoro, 39 were 3D C-arm, and 27 were with O-arm navigated. The ultimate result, though the sample size was 27, the O-arm navigation shows significantly reduced pedicle screw misplacement, which was 1%, and compared to 3D C-arm and 2D fluoro guided, if you see, it's around 7.29 and 5.916. So this is the difference of accuracy of placement of O-arm and navigation, and it's really appealed us that these kind of outcomes we really can give it to the patient. And when we see, they have studied the breaches, the medial and lateral breaches, and if you see the last column where the O-arm is talking about, they had number of breaches is in the study is only 1, and that was only in 2 to 4 millimeter breach in one case. Otherwise, it was super accurate. I think this is going to be very, very important when we analyze our own patients. And this is the outcome of their paper, which demonstrated the O-arm navigation for spinal fixation provided additional benefits in reducing total radiation exposure to the patient and providing greater instrumentation accuracy with comparable operative time, while eliminating radiation to the theater staff as well. And this is one important thing. All the healthcare workers are going out of the theater, because when the O-arm is shooting, no one is inside. That is a big advantage, and the patient takes that radiation only once, and that's also very, very minimal. This is one of the important paper which had the significant impact in international orthopedics, and this is a systematic review and meta-analysis by Feng et al. And this is again a recent paper. This is a paper of study of 8 recruited systematic reviews. They actually scrutinized 91 articles, and a lot of articles they had to remove because of duplication, and articles were not comparing C-arm and O-arm and all these things. Finally, they could come up with only 8 papers in last 5 years, and where they again showed the specificity and accuracy in navigation coupled with O-arm was significant advantage in comparison. That was the outcome of the systematic review. And this is how this is very, very useful in future generation. I think this is going to be there all over the place sooner, because as the evolution is happening, we are getting better outcomes, and this is going to be the next generation thing. Again, now I would like to talk about 3 to 4 important papers which are specific to the specific indications, like this paper by Chen et al. And this is on O-arm navigation combined with microscope assisted MIS TLIF, because this is where the world is talking about MIS surgery, minimal access surgery, minimal invasive surgery, and this paper is talking about MIS and their results. If you realize 45 patients of open versus MIS, O-arm navigated MIS, and they are mentioning about operative time, blood loss, hospital stay, and accuracy. The accuracy rate of pedicle screw in the novel MIS TLIF group guided by O-arm was 96%, and versus the open group, which was 86%. Again, this is very, very important. When it is guided with O-arm nav, it is 96.4%, which is a very, very good outcome, I can say, from their study. And the conclusion was less blood loss, shorter hospitalization stay, higher accuracy of pedicle screw placement, and faster recovery. I will just support them for this, but at the same time, even if you're doing navigation MIS, it will be the similar outcome. I don't think accuracy is the only thing probably they are adding from their paper. Our experience, again, in MIS with high grades, we are lucky to use this, and we are really happy because the time taken for putting the pedicle screw is extremely less we are directly going on the navigation, and this is a great tool for help in MIS fixations. We have everything with navigation, and once we take the first shoot by OARM, then it is integrated with the navigation. We don't need to do much. We have all the probes which are attached to the still station, and we can check it in all the three dimensions. That's the beauty, that you can see it in all the three dimensions: sagittal, coronal, and axial. And you have all the probe, the starter, the taps, all the system with the navigation, so that the chances of you hitting anything wrong are very, very less, I will say, or almost not there. This again a paper on cervical spine, and we always are skeptical at times in cervical spine accuracy in high cervical C1, C2 or subaxial spine. And this paper by Jung Hur et al. In clinical spine surgery in 2019 is explaining about their experience of C1 lateral mass and C2 pedicle screw, where they have found around 4 of 90 and 10 of 92 screws had some cortical violation in OARM navigation. And when we detailed study about their paper, they're talking about initially 60% of the patients were having significant breach during beginning stage, 40% during adaptation stage, and none during the expert stage. And this is their paper by the Harms technique. I think this is an important study, because anyway, cervical spine needs a lot of expertise, experience, and people who are doing it open or MIS with navigation. I think they know the anatomy. It's ultimately, you have to have your good anatomy, a good concept about C1, C2, and then surgery becomes comparatively better. This is the additional tool. That's what I personally feel. But it's definitely adding on, as they're talking about the screw placement accuracy marker. If you see they subdivided into 4 groups: Group A, Group B, Group C, and Group D, where they have seen that Group A is with perfect within the pedicle, violation of cortex less than 2 millimeter, violation of 2 to 4 millimeter, and violation of more than 4 millimeter. I think this is going to be the accuracy thing, and it is definitely helping people who will be using it. And if you see the violation of medial, lateral wall, superior and inferior wall, that is also accounted in this navigation and OARM. They ultimately speak about the use of image guidance system seems to be beneficial for high cervical instrumentation, which requires much experience and steep learning curve. Again, we have our own share where we are doing the cervical pedicle C1, C2, and we are extremely happy so far with this, because you are seeing the vertebral artery, you are seeing the medially seeing the canal, and the chances, you have to be very careful. At times the cervical pedicle can be sclerotic. You have to be very careful while going with your instrumentation, but this definitely adds up to your expertise, and life becomes really easy when you do that, and you have a lot of time to maneuver. You don't need to rush for doing this, and it appears to be quite easy. But we never did a cervical pedicle screw before in 17-18 years. We were always worried. We were happy with the lateral mass screws so far in subaxial spine, but we have realized the strength, the pull out, it's amazing. It's really very, very good with the cervical pedicle screw. So I think this is definitely going to add up to our practice and everyone's practice for giving better outcomes in situations which demand cervical pedicle screw. This is again an original article talking about the radiation exposure, which is very, very important, because we were thinking whether, if we are planning to get this OARM, we should know how much radiation it will cause. And this is the article by Chang et al., which is in World Neurosurgery, is talking about 90 consecutive MIS-TD patients, and their average effective radiation dose was 0.4 MSV versus 0.3 MSV. And when they subclassified in single level, the radiation is 2 times to the normal C-arm, And but no radiation to any OT personnel because everyone is out. That's the advantage. But in 2-level interbody fusion, it is nearly same. It is equal, and that was the experience of the guys from this article. I would like to add that the body mass index, when it is increased, the advantage of OARM is significant because there are more number of shoots in CM, and that is what also is mentioned by their paper, where if there is more BMI, OARM navigation is more superior in terms of less radiation. And this is what the conclusion was. Ultimately, what we were discussing is the radiation is not an worrisome thing, and with the newer versions, it is again 50% less. The newer one, the OARM O2, is got significant less radiation, and the time of shoot is not 4-5 minutes like a CT scan. It is just 13 seconds to the patient, 13 second scan, and that's it. You get everything. I think that's a big advantage. And you can do this in all the spine, cervical, thoracic, lumbar. There is nothing that we cannot do in spine, at least. That's a good advantage of OARM and navigation. This was an article which we reviewed, and we really liked in trauma, because we do get a lot of trauma patients. And this is from British Journal of Neurosurgery in 2016-17, which spoke about the experience of placement in spinal injury, and around 587, a large study, 278 were OARM group and 309 were CARM group. And the number of screw placed was significantly higher in CARM group as compared to the OARM group. If you see, the number of patients were not significantly different. Around 30 was the difference, but the number of screws were significantly high in the CARM group. However, the OARM group had significantly less screw mal placement, and that is the important thing, which they are talking about 0.93%, which is compared to the CARM group was 8.79, which is reasonably more than the OARM group. And I can say around 99% accuracy in traumatic spine, which is very, very good in this 587 patients. And the conclusion was OARM navigation exhibits higher accuracy screw placement in traumatic spines. We always think about the spinal deformity, and these two papers are very, very important from OARM navigation view. The pedicle perforation while inserting screws in AIS, and risk factors and effect of insertion. And this was published in Spine, and this was an observational study of 404 screws. The rate of screw deviation can increase significantly to 12% after insertion of 8 was something new for us. After putting 8 screws, you have a rate of deviation. And in general, the inference was pedicle perforation rate by the 9th screw or subsequent was higher than the previous 8 screws. And most of them were around apical region. So this is one important study which we realized something new concept, which we have realized that after 8 to 9 screws, we start deviating slightly, even in CARM or in OARM. And our experience, again, with severe deformity is very satisfactory so far. And this is the initial probing where we are just palpating and we are feeling. Once we palpate, then we can go. These are the deformed apical regions where it can become very, very tricky at times. We may breach, and we all have experienced that, missed beat while going anterior with the probe sometimes, and in concavity, we don't realize at times. And these things can be really negated with the OARM navigation, and that's a big advantage. I will vouch for this. Again, this is a paper in Eurospine Journal in 2016 by Jin et al. And does intraoperative navigation improve the accuracy of pedicle screw placement in apical region of dystrophic scoliosis, secondary to NF1? And this is a comparison of OARM versus navigation. Again, this is one of the very, very important papers of the sample size is 32, which is again large for dystrophic NF1. And accuracy rate of pedicle screw placement at the apex was significantly higher in OARM group 79% compared to the freehand, which is 67%. And I think that is going to be a big changer for everyone. And we are hoping for better papers, but what papers are already there in last 4-5 years are talking very high about the accuracy in apex in scoliosis, which is very, very important. And medial perforation was significantly minimized by using O-arm navigation, again, which is a very, very important thing from this paper. I would like to talk about spine tumor, and there are not many papers about spine tumor in and O-arm navigation, but this is one article which we found from the PubMed, and because we did a couple of tumors, and that time we were searching, and this is the paper which spoke from Russia, and it's talking about the primary and metastatic tumors, which mentions that the possibility of intraoperative identification of location and extension of the tumor in bone tissue facilitates adequate tumor resection. And that is the big beauty of O-arm, where we can see how much you have resected, whether you have some margins are remained or you need more. So this is one important thing, and you can actually see the vessels, neurological structures on table real time 360 degrees. So this is a big advantage in spinal tumor. As we all know, O-arm is 2D and 3D we can use on table, and it's a real time high quality intraoperative imaging. We always believe that the accuracy is important, as our field is little complex, but in situations where this can be additional to us, it is definitely big help. And we have changed significantly in our practice, where we have started doing more MIS surgeries, more cervical pedicle screws, complex deformities. We are using more screws in apex, and even for fellows we can supervise, and their anatomy can become better. More or less the advantages are similar like a minimally invasive surgery, because you really can see what's happening out there, and this is a big advantage. And I will say disadvantage, not really. It's more technically demanding, steep learning curve, increased operative time in initial days, and cost, that's a concern. Usefulness, I can vouch for this all usefulness in all this MIS, revision, challenging anatomy, tumor, deformity, and even osteoporotic spine, where we will not breach any pedicle. There will not be any violation, because you go in exactly where you want. And just one example I would like to give: the same boy, 9 years, with impending neurological deficit. One leg was weak and he was worsening rapidly. And this is where we got the big advantage in this deformed complex level, and a small pedicle we really could maneuver well, and we could put our screws. This was the beauty of O-arm. And if you see that even if the narrow pedicles we could tap well, we could get in well, and at the apex we were lucky to get a good purchase in this complex case. And this was the outcome, the final outcome. We could do the VCR and we got a good alignment. We are doing the recording of the post of X-ray, on the O-arm, and this is really showing us exact placement of the screws and significant correction in this very severe congenital hyposcoliosis. So these are some advantages of this unique advanced system. And these papers have really guided us about the placement and the accuracy, and it's really worth considering. And I'm just sharing some examples how these papers have influenced, and O-arm has influenced our practice, and we have changed in this high angulation with cervical myelopathy. We could really do a good decompression and fixation, and this is a power screw C2. We could get good correction and alignment with this. And in tumor cases, this is again a case of ABC, where we could completely take out the lesion, and we were very happy we could see it on table after removal, and then we could pack it with bone graft and we fixed it. Some cases like this where it is a 2-level lysis, we could do a MIS fixation for both the levels, and we really were lucky, and we are getting better and better by the time. And this is again a cervical pedicle screw, which we never thought we will do it in our practice, but these papers and the instrument is really addictive for betterment and accuracy. And these kind of cases which are very, very severe with worsening neurology and kind of lambda spine, what we call anaconda spine, we can really get very good placement with this instruments with navigation. And I think that is a big advantage. And I think future belongs to all these advanced techniques with appropriate indications, I will say. And in whatever our experience in recent time was really good, and all these papers are coming out with mainly accuracy for safety and precision for safety. This is where the world will be going tomorrow. And I definitely think that you need training, you need discussion with your core team. That's very, very important. And this is the last year's image when our chairman was very happy with us, and this is our complete team. And as we talk about the generation AI, it's going to be there. And definitely all this is going to help all of us in better outcomes in our practice. This is our current team with my all colleagues, Dr. Ajay Kothari, Dr. Siddharth Iyer, Dr. Pramod Bilare, Dr. Rokde, Dr. Javle. It's a team of neuro and spine surgeons, along with our chairman and academic chair. Thank you everyone, ASSI, for giving us this opportunity to share our practice and the papers which influenced our practice. Thank you very much. Stay safe, stay healthy. Thank you.